factual chart in medicine, we'll read this one. Okay, pulling lesion and pushing lesion. If there's a pulling lesion, whether it can be collapse or fibrosis. Okay, if there's a collapse, the percussion will be dull and fibrosis will be impaired. If there's no pushing or no pulling, that means there's a consolidation, and consolidation the percussion will be dull. Pushing lesion, like for example pleural effusion, pneumothorax. Pleural effusion percussion will be stony dull. Okay, and in pneumothorax, since there will be large amount of air, so it will be hyper resonant. Okay, so most frequently asked question stony dull. They have asked 2 times in FMG and 1 I think NEET. If it is stony dull and percussion, answer will be pleural effusion. Hyper resonance, it is a pneumothorax. In all the case, okay, breathing sound will be absent or decreased. In consolidation, there is a bronchial breathing. So if you the X-ray, now in X-ray in collapse, you are totally white and homogeneous, but in fibrosis, there is a heterogeneous and white. In consolidation, you know the hallmark is a consolidation. There will be air bronchogram. In pleural effusion, everyone knows there will be white with minuscule fluid level. In pneumothorax, hypertranslucency area with compressed lung margin. Now this is the master chart. Okay, you have to remember this at any cost. FEV1 divided by FVC ratio, normally 0.7 to 0.8. This FEV1 and FVC ratio is also known as FEV1 1%. Normally 0.7 to 0.8. If it is less than 0.7, the diagnosis will be obstructive lung disease. If it is more than 0.8, the answer will be restrictive lung disease. In obstructive, next step we'll do a bronchodilate reversibility. Okay, just give a salbutamol. If FEV1, okay, it's increased by 12% after SABA inhalation, the answer will be it can be asthma or bronchiectasis. If it's not increased, if you are 12% increase of 8, 6, 7, answer will be COPD. COPD has 2 variants, emphysema and chronic bronchitis. Fine. COPD causes, if you see the upper lobe, the cause of upper lobe COPD is cystic fibrosis, and so there's a post radiation and secondary tuberculosis. In middle lobe, it is ciliary dyskinesia and mycobacterium avium complex, and in inferior lobe, it is mostly idiopathic, or it can be chronic this interstitial lung disease, and this will be chronic aspiration. Okay, fine. And there's a gold classification. Always remember, gold 2 is plus 50 and gold 3 is 30. So whenever we add this 50 plus 30 will be 80. So highest marks will be 80. If 80 or more than 1, more than that, gold 1. Lowest is 30. Now if there's third one is 30. If less than 30, it will be gold 4. So just remember, gold 2 and 3, 50 plus 30, gold 2 it's 50%. Okay, and gold 3 is 30%. If we add both, what will be 80. So if 80 is the highest marks, okay, point, so 80 means gold 1 and 50 plus 30. If it's less than 30, it will be gold 4. Fine. Just remember 50, 30. 50 is gold 2, 30 is gold 3. Now let's talk about here asthma. Okay, there is a positive exercise challenge test. When you do, they will fall in FEV1 by 12%. It's very opposite of a bronchodilate reversibility test. When you give a salbutamol, the FEV1 will increase by 12%. But don't give him salbutamol. Ask him, go and run do one round of a ground. When you started round, now the FEV1 will decrease by more than 12%. Okay. But if you talk about peak expiratory, peak will be always fall more than 15%. Okay, so bronchodilate reversibility test and exercise challenge test will be opposite for in case of FEV1. Okay, after for exercise challenge test, FEV1 should be decreased by more than 15%, and definitely in asthma patient, FEV1 FVC ratio is less than 0.7. That means low FEV1 FVC ratio. Diurnal variation more than 13%. Don't get confused. Okay, more than 12, more than 15, more than 13. More than 13, it is a variation. I think they have asked in FMG this. So diurnal variation for asthma in case of peak of flow rate will be more than 13%. Now COPD assessment score, earlier it was ABCD score, now it is a AC score. It's very simple. Here we will give a MMRC score. Fine. If MMRC score is 1 or less than that, fine. So see whether it's a exacerbation, there's any severe exacerbation, or okay. For AC is a COPD AC score, assessment is done on the basis of MMRC score. Okay. If there's suppose no severe exacerbation or this exacerbation but non-severe, 1 or even absent, so it can be A or B. In A or B there will be no severe exacerbation. Okay, normal mild exacerbation can be there, or that can also be absent, so it can be A or B. So A have MMRC score 1 or less than that, B have MMRC score 2 or more than that. Rest all, that means non-severe exacerbation more than one time or any severe exacerbation, it will be a group E. Okay, there is no C, listen. Okay, A, B, E, it's called AB score. If for A just give a salbutamol, for B give LABA and LAMA. For LABA and LAMA I consider X. So in group E will give X, both LABA and LAMA, but in high dose. But suppose the patient is along with COPD, he also has asthma plus eosinophil is more than 300%. So along with this LABA, LAMA, add inhaled corticosteroids. Now if FEV1 is less more than 0.8, then it will be a restrictive lung disease. It is more than 0.8, that means FEV1 has been increased, FVC has been decreased. Yeah, FVC has to be decreased. Now that's after, if the denominator will decrease, then only it will be more than 0.8 or 80%. So in restrictive, ratio will be more than 0.8, but FVC is less than 0.8 or 80%. In restrictive means lung is very small, so in all restrictive case total lung capacity will decrease. Okay, now in restrictive we always see diffusal lung capacity for carbon monoxide. It can, and we will see residual volume. Both residual volume and diffusion capacity of lung for carbon monoxide can be normal or low. If it is normal, that means defect is outside the lungs. For example, kyphoscoliosis, neuromuscular disorders such as Guillain-Barré syndrome, myasthenia gravis, Bernard's, this is amyotrophic lateral sclerosis, polio. If it is both diffusion capacity and residual volume is decreased, that means defect within the lungs. For example, fibrosis, interstitial lung disease, pulmonary artery hypertension. Pulmonary artery hypertension is associated with limited systemic sclerosis. Interstitial lung, entire lungs is increased, entire systemic lung is increased. Interstitial lung disease, entire system of lungs is affected, so it is associated with systemic sclerosis. In pulmonary artery hypertension, I remember lungs is normal, only the blood which is supplying the lungs, that is pulmonary artery, is affected. It is limited to pulmonary artery, hence pulmonary artery hypertension is associated with limited systemic sclerosis. All the occupational lung disease of silicosis, asbestosis, since it's a restrictive, total lung capacity will decrease in both, whether it's extrinsic or intrinsic. If we talk about the residual volume, okay, residual volume, diffusion lung capacity will be low in case of intrinsic. So if residual volume is low, so the ratio of residual volume and total lung capacity, since residual volume also decrease and total lung capacity is also decrease in intrinsic, so decrease will neutralize, so the ratio will be normal. But in case of extrinsic, okay, residual volume will be normal, but since it is a restrictive lung disease, see, restrictive means, either it's intrinsic or extrinsic. In restrictive, lungs is total lung capacity, it's always decrease. In restrictive, lungs is compressed like that. Okay, so in extrinsic, though residual volume will be normal, but total lung capacity will be decreased, so definitely ratio will increase. Now see, this is the most frequently asked question. Okay, if you ask me to read only one topic in systemic pathology, I'll ask, go and read lung cancer marker, and second you can read immunofluorescence for that nucleolar pattern, centromer pattern, to identify different type of rheumatological disorder. from entire patho. Okay, I'm saying. So the marker of adenocarcinoma is napsin and small cell synaptophysin chromogranin, and both adenocarcinoma and small cell carcinoma have TTF1, tissue thyroglobulin factor 1 positive. Okay, so adenocarcinoma napsin, small cell, there will be synaptophysin chromogranin, and both will be TTF1. Squamous cell carcinoma, there will be P40 and P63. In P40 at 23, that is it will be 63. P40 and P63. Fine. So marker is also finished. Now let's talk about respiratory failure. In respiratory, normally the partial pressure of CO2 is 45 to 60, okay, mm of mercury. See, partial pressure of CO2 is more than 45. That means CO2 has been increased. It's called hypercapnia. Okay, if it's less than 60, okay, sorry, just remember the value of in for respiratory failure 45 to 60. Okay, if it's more than 45, that means CO2 has been increased, and if it's less than 60, decrease means oxygen has been decreased. If oxygen has been decreased, it's called hypoxemia. 45 increase means CO2 has been increased. It's a hypercapnia. In type 1, type 2, there will be low partial pressure of oxygen. That means partial pressure of oxygen will be less than 60, hypoxemia. Okay. Type 1 is also called hypoxemic respiratory failure. Type 2 is called hypercapnic respiratory failure. In hypoxemic respiratory failure, partial pressure of CO2 can be normal or decreased, but never high. In hypercapnic, partial pressure of CO2 will be high. Once again, I will repeat, in both type 1 and type 2, the partial pressure of oxygen will decrease. So how to differentiate? Just see the partial pressure of CO2. If it is increased, definitely it is a type 2 hypercapnic. If it is normal or decreased, it is definitely hypoxemic. Hypoxemic cause, it can be it can be pulmonary artery thrombosis or pulmonary artery embolism. Okay, so it can be interstitial lung disease. Inside the alveoli there can be accumulation of fluid, so it can be acute respiratory distress syndrome, pneumonia, especially ARDS associated with pancreatitis. So pancreatitis, ILD, pneumonia, ARDS, they are all associated with type 1. In hypercapnic, partial pressure too high, is pneumonic COPD. C for central causes, for example brainstem injury or narcotic use. Okay. O for obstructive disease, obstructive causes, for example foreign body, severe COPD. P for peripheral causes, for example neuromuscular disorder. Okay. D for diaphragmatic injury. So in hypercapnic pneumonic COPD, central cause, obstructive cause, peripheral cause, and diaphragmatic injury. In both central cause and peripheral cause, okay, both cause, there will be hypoventilation. Okay, hypoventilation. But okay, so both central and peripheral cause will be hypoventilation, but they have normal alveolar arterial oxygen gap. Central and peripheral will be hypoventilation along with normal alveolar arterial oxygen difference. Type 3 we always associate with perioperative respiratory failure associated with general anesthesia. Type 4 we always shock related. Now let's talk about a pneumonia. Community acquired pneumonia and nosocomial pneumonia. Community acquired pneumonia is basically occur outside the hospital in the community. It can be typical, atypical. Typical most common cause is streptococcus pneumonia. Atypical mycoplasma. What drug of choice for community acquired is typical, atypical, other always azithro. Okay, remember azithro never kill anaerobic organism. They never kill anaerobic organism. Mycoplasma don't have cell wall. Okay, so no need to give amoxicillin, because amoxicillin is a penicillin which is cell wall inhibitor, and mycoplasma don't have cell wall. So, okay, though they don't have a cell wall, but generally those organisms who don't have cell wall, they can't be cultured in cell-free media. Okay, because those organisms, for example rickettsia, mycoplasma, they don't have cell wall, so they are obligatory intracellular organism. They need cell in order to grow. So mycoplasma don't have a cell wall, but it can be grown on cell-free media like PPLO. Okay, mycoplasma don't have a cell wall, but it can be grown on cell-free media, culture media, and culture media name is PPLO. Hospital acquired pneumonia. Okay, nosocomial pneumonia is generally considered ventilation associated pneumonia. Hospital acquired pneumonia generally occur after 2 to 3 days of after admission. Most common is gram-negative bacilli. Example, you know, gram-negative bacilli is E. coli. Second is Staph aureus. Okay, ventilation is especially they occur after 2 to 3 days of ventilation, invasive mechanical ventilation, early within 5 days of ventilation. Okay, and late after 5 days, but generally it is a late ventilation associated pneumonia, and most common cause is Pseudomonas. Second is Acinetobacter. For Acinetobacter, drug of choice will be carbapine, but if it is not responding, add colistin. Okay, once again, early ventilation pneumonia is causative organism is Streptococcus pneumonia, like that of a typical committee acquired. In typical committee acquired, most is Streptococcus pneumonia. So in early ventilation pneumonia will also be Streptococcus pneumonia, and other is Haemophilus influenza. Now let's talk about curve. Okay, C for confusion, U for urea, more than 7 millimole or more than 40%. Respiratory rate is 30 or more than that. Okay, just remember 30. For I remember 40 and 30. B for blood pressure, systolic it should be less than 90, plus minus diastolic BP less than 60. Age should be more than 65. That's why it's called CORB 65. But recently there's a modification in CORB 65. They have removed the urea finding. Okay, blood urea finding. So blood urea nitrogen has been removed. So this elimination removed lab investigation. So now modified CORB is done clinically. You see just confusion. Okay, you see the respiratory rate, you can see the BP and ask or age. So in modified CORB, no need to a lab investigation. If the score is 0, 1, 2, 3, 4, 5, if first 0 and 1, it's low score, and 2 or more than that. Okay, first 0 and 2 score is 0 and 1 score is low. In low, we always give our drugs in oral form. 2 is moderate, 3 to 5 is severe. In moderate to severe, a route of drug should be IV more than oral. Okay, 0 and 1 oral drugs is given, and they are followed on the basis of OPD. Okay, if the score is 2, admit in the ward. If it score 3 or more than that, admit the patient in ICU. For 0, 1, 2, okay, if there is no comorbidities, for example diabetes mellitus, there is absent, so just give azithromycin. If comorbidity is present, in spite of azithromycin, we have to add beta lactams. Okay, yeah, if you do not want to give 2 drugs, azithro plus beta lactam, then just give single drugs, fluoroquinolone. In ICU patient, always prefer fluoroquinolone. This is a single best drugs. But if you want to give 2 or more than that drugs, we can give beta lactam ceftriaxone plus azithromycin. CORB 65 is frequently asked question in INI set. Okay, so for home-based treatment and ward-based treatment, we always see comorbidities. If there is no comorbidity, just single drugs, azithromycin. If it is a comorbidity, just add beta lactam ceftriaxone. Okay. So how even suppose score is patient is in ward. Okay, so if there is no comorbidity, we give azithromycin. So what is the difference? In difference is that of the route of drugs. In moderate and high, the route of drug is changed. Okay, it is IV more than oral. Oral is generally when patient almost improved and is about to discharge, then we shift the patient to the oral drugs. In ICU, single best answer will be fluoroquinolone. Yeah, give beta ceftriaxone plus azithro. But suppose there is a pseudomonas. Okay, add all these drugs, means fluoroquinolone plus azithro plus ceftriaxone. Suppose if you do not want to give fluoroquinolone, instead of that we can get aminoglycoside amikacin. Okay, and in beta lactams for pseudomonas, we give an anti-pseudomonas beta lactam, that is piperacillin tazobactam. So normally I say whenever they say ICU, give fluoroquinolone या azithro plus ceftriaxone. If they say pseudomonas, add all these three drugs: fluoroquinolone, ceftriaxone, azithro. Ceftriaxone means in pseudomonas, add all these drugs: fluoroquinolone, beta-lactam, and azithro. In beta-lactam, we give piperacillin, tazobactam. But if they say they are methicillin-resistant Staph aureus, or suppose the patient is IV drug abuser, here we give the beta-lactam will be linezolid, okay, and fluoroquinolone. If suppose patient you give in MRSA or drug abuser, the drugs MRS will give a methicillin resistant, so we will give a vancomycin plus fluoroquinolone. But if vancomycin also resistant, so we give a linezolid. Okay, BF means it's a beta-lactams and fluoroquinolone. Beta-lactams, MRSA, we know vancomycin. If resistant, linezolid. Now let's talk about pneumonia. Okay, Streptococcus, Staph, and Klebsiella. In Streptococcus, there will be lobar pneumonia, in lower lobe consolidation pneumonia, and the sputum will be red rusty. In Staph, there will be bronchopneumocele and bilateral patchy infiltrate. The buzzword will be bronchopneumonia and bilateral patchy infiltrate. Okay, pneumocele and long abscess is both in Staph and Klebsiella. So this cannot help you differentiate Klebsiella and Staph because pneumocele, long abscess are seen in both. Best way to differentiate is bilateral patchy infiltrate and bronchopneumonia. It's a hallmark for Staph aureus. Streptococcus hallmark, lower lobe consolidation and red rusty sputum. For Klebsiella, buzzword, it's a red current jelly sputum. Okay, Streptococcus red rusty. Here will be last one. It's like a gel. Okay, and Streptococcus will be lower lobe consolidation. Klebsiella will have a right upper lobe consolidation plus bulging fissure. Bulging fissure is a buzzword for a Klebsiella. Okay, now we will read this atypical pneumonia, for example Legionella and Mycoplasma. Atypical pneumonia is mainly caused by Mycoplasma as compared to Legionella. Mycoplasma, also known as a walking pneumonia or eaten agent pneumonia. Extra pulmonary clinical feature of Mycoplasma is it affects CNS. So for example encephalitis, Guillain-Barré syndrome. Then come to heart or cardiovascular system, it will affect myocarditis, hematological condition, cold agglutinin, hemolytic anemia. In ortho, it will arthritis, skin, Stephen-Johnson syndrome. So always diagnosis is based on PCR more than antibody detection. Okay, for Mycoplasma we always prefer macrolides. Okay, the virulence factor for Mycoplasma is pi adhesion protein. This is a recent DAMS ionisate CBT. Okay, pi adhesion protein, it's a virulence factor for Mycoplasma. Okay, just see. Okay, chlamydia pneumonia is associated with adult onset asthma. Okay, suppose I have asthma and I have suffered pneumonia, so most probably I am infected with chlamydia. Klebsiella pneumonia is associated with bronchopulmonary disease and diabetes. And Klebsiella buzzword will be fissure, right upper lobe consolidation. And in background there will be diabetes or bronchopulmonary disease. In Haemophilus influenza pneumonia, they are associated with infant. They generally affect infant. Okay. Now Legionella, route of inhalation is aspiration more than inhalation. Aspiration means in form of water droplet. Okay. Here the pneumonia, and this pneumonia is such a severe that patient will cough blood. Okay, hemoptysis, and there will be severe chest pain, but diarrhea will be watery. Okay, watery diarrhea along with hemoptysis. Since there is watery diarrhea, there is loss of sodium, potassium, there will be hyponatremia. They generally occur in immunocompromised patient, HIV patient, like that. Generally they are seen after discharge from hospital. Suppose there is a patient of HIV, they are discharged. Now when they reach home, they suffer from a pneumonia. Basically they got an infection in the hospital at the time of discharge, and when they reaches home, they suffer from a pneumonia. There will be a typical history like that. That a patient is admitted and once he discharged, after during follow-up, you found to be suffering from a pneumonia, like that. Now if you do a gram staining in this patient, there will be no organism, only you will see a neutrophil. Okay, so how to diagnose? The best way to diagnose a direct fluorescence antibody. Okay, we take the pleural fluid and we will do a detect the antibody against Legionella by with the help of direct fluorescence. Gram staining do not show any organism. Okay, they only show neutrophil. So but if you want to detect organism, just culture that species, culture that specimen in the BCYE culture medium, buffer charcoal yeast extract. They have asked question, a patient of pneumonia, patient with hemoptysis, watery diarrhea, immunocompromised. Okay, this is the only pneumonia which is associated with the diarrhea. There is no other pneumonia which can be seen with the diarrhea. Okay, only pneumonia which is associated with watery diarrhea. It's a Legionella. Pneumonia will be basically hemoptysis. Okay, they will say hemoptysis, hyponatremia. Then you just remember it's a Legionella, culture medium BCYE. Most common extra pulmonary complication is carditis. Treatment will generally macrolides, but generally here we prefer fluoroquinolone. Okay, Legionella also causes one disease called Pontiac fever, but this Pontiac fever occurs in immunocompetent patient. Okay, immunocompetent patient, and it's non-fatal. Let's talk about pneumocystis pneumonia. Pneumocystis pneumonia basically their patient will have fever but without chill and rigor. Chest X-ray will be initially normal. After that, perihilar infiltrate. After perihilar, there will be diffuse interstitial infiltrate, and later on there will be pneumatocyst like staph and Klebsiella. How to diagnose is basically we take a bronchoalveolar lavage. Okay, we can also do routine. We can check a routine sputum. We can also do histopathology. In histopathology, we found a foamy alveolar infiltrate macrophage. Basically, foamy alveolar infiltrate is basically a macrophage. Macrophage means monocyte. Okay. In bronchoalveolar lavage, we see a cyst because pneumatocyst pneumonia has a cyst. Okay, so we can easily visualize cyst with the help of Giemsa stain or Gomori methamine silver stain or immunofluorescence stain. Basically, they will have two stain to see the cyst of pneumocystis cerevisiae. It's a Giemsa stain, Gomori methamine silver stain. Remember, they have asked multiple times Gomori methamine silver stain, Giemsa stain. And on lab investigation, there will be increased interleukin 8, which recruits neutrophil. Drug of choice for treatment as well as prophylaxis of pneumocystis pneumonia is cotrimoxazole. Cotrimoxazole is basically trimethoprim sulfamide methoxazole combination. If partial pressure of CO2 is less than 70, okay, or arterial alveolar gradation is more than 35 mm of mercury. Less than 70 is half is 35, more than 35. Or then only add steroids. Generally, no need to add steroids because these patients are already immunocompromised. So we add only steroids. See partial pressure of CO2, it's less than 70. Okay, or difference or oxygen concentration in alveoli and arteries more than 35%. Then add steroids. Okay, done.